Let us start. So, just a recap. Massive proteinuria, hypoalbuminemia or edema, nephrotic syndrome. Three classical features. Nephrotic syndrome means massive proteinuria of more than 3.5 grams per 24 hours or urine protein creatinine ratio of more than 3000 milligrams per gram. Less than 30 milligrams proteinuria, microproteinuria, normal. 30 to 300, microproteinuria. 300 to 3000, macroproteinuria. More than 3000, massive proteinuria. And hypoalbuminemia, less than 2.5 grams per deciliter of albumin or frank edema. This is called nephrotic syndrome. Additionally, hyperlipidemia with total cholesterol more than 350, increased thromboembolic risk may be there as adjoining factors. Now we have got three areas: the primary, idiopathic, the secondary, and the genetic variants. The primary one is podocytopathies. 80 to 90% of the adult cases are podocytopathies only. Majority are in pediatric age group. Minimal change disease, focal segmental glomerular sclerosis, membranous gland nephropathy are the other ones. Then secondary ones, diabetic nephropathy, end-stage kidney disease, systemic lupus erythematosus, infections, amyloidosis, medication. Genetic presents often in the first 3 months of life. There are 3 mutations you can expect: NPHS1, nephrin type of mutation, podocin mutation, NPHS2 or WT1. These are the 3 genetic variants. Now, underfill hypothesis and overfill hypothesis. Massive proteinuria, hypoalbuminemia, decreased plasma oncotic pressure, fluid shift into the interstitium, hypovolemia, triggers RAS activation, sodium and water retention. Overfill hypothesis, podocyte injury, deactivation of the epithelial sodium channel, that ECNA channel is disturbed and in the collecting duct, and there is a primary renal sodium retention, leads to volume expansion. Then modern consensus recognizes both the mechanisms are synergistic and produce a clinical edema in a given patient. Now, what are the pathophysiology to? Node 1. Kidney excretes massive amounts of albumin, plasma oncotic pressure drops, sending distress signal, and liver understands that there is a necessity to synthesize proteins, blindly upregulates all the proteins, so much so lipoproteins are also upregulated. Node 4, kidney simultaneously loses key lipid clearing enzyme, particularly the LCAT enzyme. So much so, the LCAT enzyme absence, the lipoproteins are not cleared from the system. So, this results in severe hypercholesterolemia. This we have already understood. About pathophysiology 3, the homeostatic imbalance, antithrombin 3 is in, and then protein C and protein S. These proteins are lost in the urine. And the fibrinogen, factor 5 and factor 8 are overproduced. These together produce high thromboembolic risk or venous thromboembolism. Now, synthesis of all the 3. So the immune trigger, genetic mutation, podocyte food process effacement or breach in the slit diaphragm, glomerular filtration barrier is leaking, massive proteinuria occurs, edema, hyperlipidemia, hypercoagulability. All the 3 I have explained. Now, the matrix 1 for primary podocytopathies. What are these? MCD, minimal change disease, FSGS, focal glomerular sclerosis, membranous nephropathy, MM. Minimal change disease, most common in children. And FSGS, most common idiopathic cause in the adult. And membranous nephropathy, most common primary cause in the adults. So, histological landmark, normal light microscopy, diffuse food process effacement in the electron microscopy. And in FSGS, segmental scarring and sclerosis and variable effacement. In membranous nephropathy, basal membrane is thickened and subepithelial immune cell deposits are seen. Clinical presentation, minimal change disease, selective proteinuria, absence of hematuria, excellent steroid response, mostly in children. Focal segmental glomerular sclerosis, often steroid resistance, high risk for progression to end-stage renal disease. Membranous nephropathy, autoimmune mechanisms are involved, autoantibodies targeting the podocyte, particularly on the nephrin, particularly on the podocyte antigens. Now, as far as classification is concerned, we use steroid responsiveness as one variable. That is, first one is SSNS, steroid sensitive nephrotic syndrome. Second one is frequently relapsing nephrotic syndrome, FRNS. And lastly, SRNS, which is steroid resistant nephrotic syndrome. Steroid sensitive means complete remission occurs, proteinuria comes down to less than 20 milligrams, and urine dipstick will be what was 3 plus or 4 plus protein, now it is 1 plus or traces. Okay, within 4 weeks, that is the cutoff point. Remember, steroid responsiveness should occur, particularly in children, within 4 weeks. In adults, you can give a little longer time. FRNS, 2 or more relapses occurring in the first 6 months or 3 or more relapses occurring in any 12-month period signals need for transition to steroid-sparing proactive therapy due to high toxicity. This is called relapsing nephropathy. And finally, lack of complete remission after 4 weeks of standard therapy requires biopsy and genetic counseling. In whom do I do biopsy? In those where I suspect the genetic forms, where there is a family history, where the patient is a child, and also when there is no steroid responsiveness. So the indication for biopsy is steroid non-responsiveness, young individual less than 5-6 years suffering it, or somebody who has got a genetic background with another sibling or another family member affected by the nephrotic syndrome. Genetic testing is highly essential. Now, what are the adult cutoff points? We are interested in the adult. Proteinuria cutoff point, more than 3.5 grams of proteinuria or 300 milligrams per gram in the protein creatinine ratio. Hypoalbuminemia, less than 30 grams per deciliter serum albumin. I am not touching the pediatric guidelines. Now, urine baseline, standard spot urine protein and urine creatinine ratio. You don't have to collect 24-hour urine. Take a spot urine, measure the protein, measure the creatinine, and obtain the UPCR or urine ACR, albumin creatinine ratio, or protein creatinine ratio. What is the guideline parallel here? First morning void is highly preferred, especially in pediatrics, to rule out orthostatic proteinuria and to avoid 24 collection errors. So, if you take first morning urine, child is sleeping or the patient is in the bed during night and there is no orthostatic proteinuria. There is a condition called orthostatic proteinuria. After prolonged standing, you will develop proteinuria. That you can avoid. And you avoid 24-hour collection also. What are the core blood biochemistry panels I do? Complete blood count, creatinine, EGFR, urea, electrolytes, albumin, lipid. Why lipid profile? We know dyslipidemia will be there. Why serum albumin? That is the diagnostic criterion. Electrolytes also you have to measure for treatment state. Creatinine and EGFR are required to measure the glomerular function. Targeted serology, what do I do? Look for hematuria, sustained hypertension, and low GFR. Screening, complement 3, complement 4, ANA antibody, anti-double strand ANA, ASOT, that is anti-streptolation O titer, to rule out the secondary systemic diseases like SLE, immunoglobulin A nephropathy, and infection-related glomerulonephritis. Now, diagnostic threshold, already we have talked about that. Hypoalbuminemia, less than 30 grams or 3 grams per deciliter. Proteinuria, more than 3000 milligrams per gram. That's very important for us. Now, you see, standard shared pathology, minimal change disease, FSGS. Both minimal change disease, MCD, and FSGS glomerulosclerosis are characterized by diffuse podocyte food process effacement, which I have shown you the slides last time, the food process disease here. What are the conditions which produce the food process one? FSGS and MCD. And minimal change disease, normal appearing glomeruli on light microscopy, accounts for vast majority of pediatric idiopathic nephrotic syndrome, and in 10 to 15% of the adults also MCD. As the name suggests, it is easily treatable compared to the other forms. Focal glomerular sclerosis, sclerotic lesions are present not throughout the kidney in a patchy manner, one of the leading causes of nephrotic syndrome in adult population. If you see nephrotic syndrome in adult population, you can think of FSGS syndrome. So healthy podocyte on the left-hand side, severe foot process assessment on the right-hand side. You see the foot processes, how nicely architectured, and the slit diaphragms are there. The foot processes are sitting right on the GEBM. Slowly, what happened? Completely flattened out podocyte, and there is no foot process at all at the other end. So this is a diagram which shows you the change that will occur. Next one, FSGS lesions on biopsy. Primary immunological FSGS, that means electron microscopy, diffuse foot process effacement is there, clinical presentation, full nephrotic syndrome, massive proteinuria, hypoalbuminemia, edema. Response, often responsive to primary immunosuppressive or steroid therapy. For example, secondary one, segmental or less severe foot process effacement, less than 80%, often non-nephrotic range of proteinuria, serum albumin is usually normal. That is, this is the nephrotic syndrome to be. Like that, the house surgeon, doctor to be, like that, is an earlier stage of nephrotic syndrome. Normal range of proteinuria, that means between 3,000 to 300 milligrams. And then the maladaptive changes are hyperfiltration, viral insult, drugs and toxins. Now, you see here, trigger one, age of onset, congenital. How do I identify diagnostic triggers? First trigger, what is the age of onset? Congenital, first 3 months, or infantile illness. And then highly associated with NPHS1, NPHS2, or WT1. Understandable. Trigger 2, initial steroid responsiveness, SRNS with non-responsive to calcineurin inhibitors, CNIs, we will see that. And trigger 3, family history, known family history of SRNS or FSGS. Trigger 4, systemic syndrome features, presence of extrarenal manifestations, suggesting a broad genetic syndrome. What you have to look for? What is the age of the patient? Is there a mutation of NPHS1, 2 or WT1? Number 2 is it initial steroid resistance? Is there? Is it non-responsive to calcineurin inhibitors? Is there a family history of SRNS or FSGS? And fourthly, are there any extrarenal manifestations suggesting a generalized genetic syndrome? From now, the management. You see the foot processes, normal foot processes, how nicely they are sitting on the capillary basement membrane there, the glomerular basement membrane and vasculature on the other side. These are based on the KDIOG 2025 International Pediatric Nephrology Association guidelines and precision medicine. These are the 3 areas we are using for this particular presentation. Now, establishing the universal support baseline. How do I do that? Control edema, control proteinuria and blood pressure, infection prevention, thrombosis management. So it is 4-pronged approach. First one is edema control, second one is proteinuria management, blood pressure management, third one is infection prevention, fourth one is thrombosis management. How do I control edema? Loop diuretics are the first line, combined with amiloride, thiazides to overcome diuretic resistance, because amiloride acts on a different mechanism, thiazides act on a different part of the nephron. That is why we can combine them. Restrict the sodium intake also to less than 2 grams per day. How do I control edema? Restrict sodium intake less than 2 grams per day. Use loop diuretic, furosemide or torsemide water. Combine, if not responding, amiloride or thiazide. Caveat here, routine fluid restriction is not recommended. What is there? Patient is edematous, let us stop fluids. Don't do that. Unless hyponatremia is there. If there is a severe hyponatremia, dilutional hyponatremia, then you restrict the fluid. Otherwise, fluid restriction is not the treatment of choice. Okay, second one, proteinuria. Use RAS inhibitors because proteinuria is best tackled by ACE inhibitors or ARBs for their established anti-proteinuretic action. Caveat, do not administer ACE ARB, specifically control edema or BP during the acute relapse. Let the edema come down, then you use the ACE inhibitors. Okay, infection prevention. Infection risk is 20% in these people if receiving alternate day prednisolone because steroid is there and also immunocompromised state. Switch to low dose daily 5 to 7 days during upper respiratory tract infections to reduce the relapses. So infection prevention, and finally the thrombosis management. This is the hypercoagulable syndrome driven by antithrombin 3, urinary loss, and fibrinogen excess on one side. Assess the baseline risk dynamically using the serum albumin thresholds. These are the 4 basic tenets of supporting the patient of nephrotic syndrome. Edema control, loop diuretic, add other diuretic, semilurid, thiazide, caution. Proteinuria, ROS inhibitors, caution. Infection prevention, reduce steroid dose in case of infection or make it alternate day. Thrombosis management, assess the thrombotic risk and manage it properly. Now, navigating the clotting risk, prophylactic anticoagulants. Should I give prophylactic anticoagulants to all the nephrotic syndrome patients? This is a question usually asked. Whenever you get a case, they'll ask you, do you want to prescribe anticoagulants? What is the trigger here? Albumin less than 20-25 grams per deciliter and membranous nephropathy. That is the condition. Risk modifiers, proteinuria more than 10 grams, BMI more than 35, immobilization, heart failure, you have to anticoagulate. Where do you anticoagulate? Higher proteinuria, higher BMI, immobilized patient, already heart failure. Heart failure itself deserves anticoagulants. Immobilization deserves anticoagulant. So there are decision for 1 and 2. High VTE risk, and that means assess bleeding risk, and low bleeding risk, prophylactic warfarin or alemdac. So if the bleeding risk is high, avoid warfarin. And then because if the bleeding risk is high, you give anticoagulant, patient will bleed. So if you assess the bleeding risk, if the bleeding risk is already higher, is lower, then you can use prophylactic warfarin or low molecular heparin. If the bleeding risk is higher, you don't use the anticoagulant. Decision for 1. Decision for 2 is the arterial thrombotic risk. Estimate risk via Framingham score, EGFR, and prior events. More than 20 per 1000 patient years, aspirin prophylaxis. You understand now what are the prophylactic anticoagulant measures I take? What is the trigger? Look at the serum albumin, whether it is membranous nephropathy. In both the conditions, anticoagulants are useful. Risk modifiers, more proteinuria, more BMI, immobilized patient, heart failure. I need to give anticoagulation. What anticoagulation? Venous, arterial. Venous, what I give? Warfarin, LMW. When the risk of bleeding is low. When the risk of bleeding is high, avoid warfarin or any other anticoagulant. Arterial risk is there. You assess the arterial risk via any of these risk scores, and if the risk is more than 20 per 1000 patient years, aspirin prophylaxis must be given. There is a clinical pearl here. Factor 10A and direct thrombin inhibitors are heavily albumin bound. You have no dabigatran, all these things, direct thrombin inhibitors, under factor 10A inhibitors, they are albumin bound. Their pharmacokinetic properties require additional study before general recommendation in nephrotic patients. So much so, don't use 10A inhibitors or direct thrombin inhibitors in these cases of nephrotic syndrome because these two drugs are albumin bound. Next one, adult podocytopathies, differentiating the clinical approach. How do you do? Track A and track B. What is track A? Adult minimal change disease. Track B, membranous nephropathy. Membranous nephropathy, basement membrane is affected. Minimal change disease, electron microscopy only shows changes, light microscopy, glomerular, no. Primary intervention, high dose glucocorticoid. Trajectory, slower time to remission compared to children. What is the time I have given there in children? 4 weeks. Here, how I can wait up to 6 weeks to say that it is steroid resistant in case of adults. In case of children, 4 weeks treatment is good enough to say they have not responded, if they are not responding. Whereas in case of adult, I have to give them 16 weeks treatment. I can up to wait up to 16 weeks before I call steroid is not worth. Okay, I must use high dose. What is high dose? I will show you. Relapsing strategy, similar to pediatric protocols, utilizing the CYC or CNIs for frequent relapses. What is relapse? More than 2 relapses in 6 months or more than 3 relapses in any 12-month period. That is the relapse. If that is there, then stop steroid and go for other steroid sparing therapies, which I will narrate in the next part of the presentation. This is track A. Track A is for what? Minimal change disease. Track B is for membranous nephropathy. Risk stratified management based on proteinuria, eGFR decline, and autoantibodies, anti-PLA2 antibodies. Okay, trajectory, wait and see approach for low risk patients. Spontaneous remission can occur in case of membranous nephropathy. Immediate immunosuppression for high risk patients. If the patient is of low risk, I wait for the spontaneous remission with a little steroid. Immediate immunosuppression is required because it is membranous nephropathy for high risk patients. I have to assess the eGFR decline, the proteinuria, and the autoantibodies. The complication profile, unlikely high risk for severe thromboembolic events. Prophylactic anticoagulation is a primary concern. Unlikely high risk for severe thromboembolic events. So you may have to think of primary anticoagulation. Now, initial episode protocol, relapse protocol. How much I give? 60 milligrams per meter square of prednisone. Maximum of 60 milligrams per day, daily for 4 to 6 weeks. In case of adults, up to 16 weeks you can try. Followed by first 4 to 6 weeks you give 60 mg. Then you are bringing down the steroid. You can see the tapering there, 40 mg per meter square on alternate days for 4 to 6 weeks. Guideline shift, avoid prolonging therapy beyond 8 to 12 weeks. Longer durations do not reduce relapse risk but increase the toxicity. What do? Start on 60 milligrams of prednisolone per day, continue for 4 weeks, reduce it stepwise, bring it 40 milligrams per day alternate days, up to a maximum of 12 weeks. Beyond that, there's no point in continuing. If you go beyond 12 weeks, it is not going to benefit the patient for relapse, and it is going to increase the toxicity. Relapse protocol, somebody has relapsed, but I can try once more the steroid. Now how much I give? 60 milligrams daily until complete remission for 3 days. What is complete remission? Urine proteinuria should be less than, dipstick should be 1 plus or less for 3 consecutive days. Okay, the definition of remission is, when you want to say remission, the proteinuria should disappear. To what extent? 1 plus or traces in the urine examination. How long? At least for 3 days, you must get that result. Not one sample. Followed by, then you give 40 milligrams alternate day for 4 weeks. Suddenly you drop it from 60 to 40 and maintain low dose. That is alternate day less than 0.5 milligrams. If frequently relapsing without toxicity. This is the relapse protocol. I told you what is relapse. Now, triad of nephrotic syndrome management. Concentrate very well. From here onwards, it is very interesting for you how you manage. Phase 1, supportive care. Phase 2, immunosuppression. Phase 3, phase 2 and 3. Phase 4 and 5, precision intervention. Okay, what is phase 1? Hemodynamic control, blood pressure control, fluid control, edema control, symptomatic edema relief, complication prophylaxis. Phase 2 and 3, targeting the podocytopathy. How do I do? By giving steroids initially or not responding, steroid-sparing medicines. T-cell dysregulation has to be corrected. Induction and steroid-sparing area. That is phase 2 and 3. Phase 4 and 5, that is a precision intervention. That means you identify the genetic defect, identify the refractoriness and the cause of refractoriness, emerging targeted biologicals. Now we have got a wonderful biological, which I'm going to show you, which can be used in cases of refractory cases. Okay, clinical part. The overreaching strategy requires all three approaches simultaneously. Don't think I will do phase 1 first, then I'll start steroid and not respond to you. After 4 years, I will do genetic testing. Not like that. Start all the approaches simultaneously. Immunosuppression cannot succeed if life-threatening hemodynamic or thromboembolic complications are ignored. That means you have to treat thromboembolic complications, excess edema, fluid management, BP management. Along with that, you also have to have the immunosuppression. Now you see, beautiful forking. Baseline, heavy proteinuria is there. That is more than 3000 milligrams per millimole. Then you give 4 to 6 weeks. You have exposed the patient to steroid. Remission has occurred. That means it has become 1 plus or DR or traces. That is the remission. Then it relapsed. That means 3 plus protein on dipstick on 3 consecutive days is called relapse. Remission is 1 plus or traces protein on 3 consecutive days after 4 to 6 weeks of steroid therapy is remission. So, okay, it remitted. Then again the relapse occurred. 2 types of people, frequently relapsing type or SDNS, that is steroid dependent, relapse during steroid taper within 14 days of cessation. That is steroid dependent means if they remove the steroid, relapse is occurring. Introduce the steroid, he is all right. Or frequent relapsing, complete relapse occurred, but again complete remission occurred, but relapse also started. This group is called as SSNS, steroid sensitive group. Complete remission within 4 weeks, standard dose of 60 milligrams. In case of adults, you can wait up to a maximum of 12 weeks or 16 weeks. Beyond that, no steroid to be given. The second fork is SRNS. These are steroid resistant. There is no remission at all at 4 to 6 weeks. Then complete remission did not occur, or even proteinuria is not showing any sign of decline after 4 to 6 weeks to steroid therapy. I must consider them as steroid resistant. This is the first fork. Clinical part in adults, time to remission threshold for SSNS versus SRNS can be extended up to 16 weeks, unlike the strict 4-week pediatric cutoff. I have already told. Pediatric patient only 4 weeks of steroid, test relapse or remission or no remission. If remission, taper steroid, wait for the relapse, frequently monitor every month or so for proteinuria. The moment relapse occurs, try again steroid. It is resistant, then we will find. In case of adult, 4 weeks is not a strict cutoff point. An adult showing some downward decline in the edema, in blood pressure, in proteinuria, level is coming down, you can expose him for a few more weeks until 16 weeks at the most. Now, phase 1, supportive care, hemodynamic axis. What are the 3 axes? Hemodynamic axis, and then the targeted treatment for the podocytopathy, the immunological treatment, and precision diagnostics. Precision treatment is the third aspect. Phase 1 is supportive care, hemodynamic axis. What do? There is afferent vasoconstriction, afferent arteriolar vasoconstriction, efferent arteriolar vasodilatation. How do I get it? SGLT2 inhibitors modulating the tubuloglomerular feedback, emerging standard of care for podocytopathies. This is an emerging treatment, SGLT2. Now, SGLT2 inhibitors are everywhere. Even for hypertension, for obesity, for diabetes, of course, for nephrotic syndrome, for any glomerular disease, SGLT2 inhibitors have become the sheet anchors now. Emerging standard of care for podocytopathies, SGLT2. Afferent vasoconstriction is tackled by SGLT2 inhibitor. Efferent vasodilatation is tackled by renin-angiotensin inhibitors, first line therapy to reduce the intraglomerular pressure. What is happening normally? The afferent vasculature is constricted. There is hypertension. Efferent vessel is not dilated. So there's so much that a lot of blood is available in the glomerulus. Intraglomerular pressure is increasing. Afferent vessel is opened, afferent vessel is closed. More blood is available. Then more filtration is occurring, proteinuria is increasing. What do? I close the afferent vessel and open the efferent vessel. so much intraglomerular pressure will be reduced. Understand? And intraglomerular pressure is the driving force for the proteinuria. Then this is what I'm saying. Emerging dual blockade is there. Now we have got endothelin antagonist, the bosentan group of drugs, endothelin antagonist, angiotensin receptor antagonists are there, ARBs. We have got a double blockade, DEARA. That is dual endothelin angiotensin receptor antagonist. That means it works like a bosentan on the endothelium. It works like an ARB on the at the ROS front. That is the dual endothelin receptor antagonist. Dual endothelin angiotensin receptor antagonist. This is called the DERA, is an emerging dual blockade. What is the clinical peril here? Maximum antiproteinuritic effect is achieved when systemic blood pressure targets are strictly met. If the systemic blood pressure targets are not met, your proteinuria will not be achieved. Why? More pressure at the afferent arteriole pushes more blood into the glomerulus. If you control the blood pressure systemically, the afferent arterial blood flow is reduced. So much so, the filtration is also reduced. So what is the peril here? I have to manage the blood pressure. So along with the SGLT inhibitors, DERAs, and efferent vasodilators, how do I tackle? Of course, by giving renin-angiotensin blockers. First line therapy to reduce the intraglomerular pressure. Now, phase 1 supportive care, the edema axis. How do I control the edema? Two things are there: sodium intake and reabsorption, and diuretic output. So I can reduce the sodium. Foundation is moderate dietary sodium restriction of less than 2 grams per day. That is one aspect. Second thing is diuretics. What diuretic I give? Loop diuretic, furosemide, tostemide, whatever is we have. Now, there is another thing called albumin binding concept. So, these loop diuretics must be protein bound to reach the renal tubule. Suppose you give Lasix, furosemide. It has to get bound to albumin to go to the renal tube for its action. Albumin itself is deficient. Okay, how can the drug be delivered to this one when the carrier protein itself is less? Then what you have to do? Either you increase the dose or you give some other diuretic to help this diuretic. Okay, severe hypoalbuminemia drastically reduces their delivery and efficiency, causing apparent diuretic resistance. Now you give diuretic furosemide, you have given 40 milligrams or say 80 milligrams per day. Patient is not urinating, edema is not coming down. Why? Why it is not coming down? There is no protein to take the drug to the delivery site. The protein is missing. How do you tackle? Either you infuse albumin from outside, or you add another diuretic, or double the dose of the loop diuretic. These are the three ways you can overcome the diuretic resistance. What are the other two diuretics I can use? Amiloride or chlorothiazide, chlorothiazidone or chlorothiazide. Okay. Now, come to the managing refractory edema, sequential nephron blockade. That means I can block the nephron at 3 or 4 stages and excrete the extra water. But what is the step 1? Dose escalation. Increase the loop diuretic dose to overcome the delivery threshold up to 240 milligrams of furosemide. What is the common side effect of furosemide? If you give large doses of furosemide, loss of potassium. Potassium loss can be there. Second thing is deafness. This loop diuretics can produce deafness, just like streptomycin and other things. These are the large dose. 30 milligrams, 20, nothing happens. 240 milligrams you are using. Deafness could be there. There could be a loss of potassium should be monitored. Step 2, intravenous administration. Instead of giving oral. Why? What is the difference between oral and intravenous? There is already edema of the gut wall because of the fluid retention everywhere. The edematous gut wall will not absorb the tablet easily. So I bypass the gut and give the injection. People will respond. Okay, what did you do? You escalated the dose with caveat of potassium and the deafness, or you bypassed the stomach and the intestines and gave it IV. What is the big difference? Stomach is edematous, GI tract is edematous, it cannot absorb the drug. So I bypass it by giving through the needle. Step 3, sequential blockade. I add another diuretic which blocks at the collecting duct and not at the loop. At the collecting duct, what are my diuretics? Thiazide diuretic I can use, which will be the downstream. Or the fourth one is administer IV albumin, increase the albumin in the blood, followed immediately by the IV diuretic, bolus to overcome severe hypoalbuminemia. What do? One side you keep giving the protein, albumin infusion, and IV diuretic you give so that the high albumin is retained and not excreted, and then water is lost. So diuresis should be controlled and progressive. What is my target? Minimum of 1 to 2 kilograms weight reduction per day. Keep weighing the patient. Suppose he is weighing 60 kilos. Every day at least 1 kilo he must lose. Then only diuresis is effective. You understand? Managing refractory edema is not that easy. You can say, injection I have given, sir, they have not responded. But what did you do if it did not respond? Did you escalate the dose? Did you choose alternate diuretic addition? Did you give by needle? Did you infuse albumin? Did you check weight loss? This is clinics, isn't it? Next one. Now, second phase, complication prophylaxis. So what did we do? We managed the albumin, we managed the fluid, and we managed the thrombosis. Why the hypercoagulability? There is excess fibrinogen, there is excess clotting factors like 10A and all, and there is less of antithrombin 3 because the antithrombin has gone in the urine along with the albumin. So protein yes, protein C, antithrombin 3 are thrown out from the body. Fibrinogen is excess secreted by the liver. So loss of urinary antithrombin 3, protein C, protein S, and combined hepatic overproduction of fibrinogen that elevated the blood viscosity, brought a thrombogenic environment, thrombotic environment. How do I intervene? Prophylactic anticoagulation indicated based on low serum albumin levels, specifically highly correlated with membranous nephropathy. That is the management of hypercoagulation. How about dyslipidemia? Should I do anything for the high cholesterol there? I know high cholesterol is an accelerated atherosclerotic risk due to hepatic compensation of the hypoalbuminemia, severe hyperlipidemia, cholesterol more than 350 milligrams per day, intervention managed with statin if lifestyle modification and disease remission fail. That means statins are always available for you to treat it. Don't wait too much. In children also, if there is hyperlipidemia, don't think a child, why should I give? You can give, but start with a lower dose. The risk of venous thromboembolism exponentially increases as the serum albumin drops below 2.5 grams per deciliter. You see that? It's a very important, this one. If the serum albumin drops below 2.5 grams, the risk of thromboembolism is exponentially increasing. That means you should always try to keep the serum albumin at least 2.5. Now phase 3, induction, the first episode. How do I induce? Full dose prednisolone 60 milligrams meter square or 2 mg per kg in case of child, maximum 60 to 80 milligrams. Duration, children 4 to 6 weeks, adults even longer duration. Early tapering prevents cumulative toxicity without sacrificing long-term remission. So when you have a chance to taper, start bringing down by 5 milligrams. You started at 60, make it 55, 50, 45, 40 like that, and make it alternate dosing also. Recent KDIOG paradigm shift, extending initial treatment for 3 months to 6 months does not significantly influence the course of illness. Shorter courses, 2 to 3 months total, are non-inferior. That means don't give for 6 months or more than 3 months, and try restrict it to 4 to 12 to 16 weeks, even in an adult. Now, how do I monitor steroid toxicity? What are the steroid toxicity that can occur? Ophthalmological. What will happen? Raised intraocular pressure. Glaucoma can occur because of steroid. Moon phase can occur. Cushingoid appearance. Weight gain. Blood pressure gain. And then anthropometry and weight you have to do. Endocrine. HbA1c will increase. Glycemia will be disturbed. and fasting glucose, postprandial blood glucoses will be increasing because of your glucocorticoid. Physical appearance, Cushingoid features, weight gain, and high velocity in adolescents, 6 to 12 months time, stunning risk of growth. People who are growing, if you observe them, steroids will stun the growth. That means growth impediment can occur. These are the steroid toxicity look for. Routine ocular examination, high velocity plotting, height velocity plotting are non-negotiable pediatric and adolescent population. What does that mean? Non-negotiable means must. Every pediatric and adolescent fellow plot the height and weight. Height velocity plotting you have to do, and also ocular examination for what? For glaucoma. Now, phase 3, categorizing the relapsing patient. Relapse occur, 3 plus protein for 3 days. That is the definition of relapse. Okay, patient remitted, but he again got 3 plus proteinuria on 3 consecutive days. Relapses occurred. Is he an infrequent relapser or a frequent relapser? Infrequent relapser, less than 2 relapses in 6 months. Treat each as an individual episode. If it is an independent, occurring less than 2 relapses for 6 months, treat it as a fresh episode, each one, just as what we have. Or if it is a frequent relapser, more than 2 relapses in 6 months, or relapsing on steroid tapering, and that is steroid sensitive very much, absolute trigger, initiate steroid sparing agents. What are steroid sparing agents will be the question. Continuing isolated steroid courses poses unacceptable cumulative toxicity risk. That means if a fellow is not responding, he is frequently remitting and frequently relapsing and not responding, and he is steroid resistant or steroid dependent fellow, equally always asking for longer term steroid, don't continue it simply because he is showing some milder response. Stop the steroid and go for steroid sparing drugs, which are shown in the later slide. Primary goal is frequently relapsing nephrotic syndrome. Steroid dependent nephrotic syndrome is not just achieving remission, but maintaining it in while completely withdrawing the steroids. So that is the pearl is you achieve a remission, but you should be able to sustain the remission. Then only you say steroid has worked. Then what I do? Steroid response as the North Star, standard dose oral prednisolone challenge, onset of nephrotic syndrome, SSNS, steroid sensitive nephrotic syndrome, steroid resistant nephrotic syndrome, North Star metric, regardless of the initial microstratification, the in vivo response to steroids remains the primary arbiter of long-term prognosis. Means a fellow who responded to steroid will have a better prognosis than a fellow who did not remit with the initial steroid exposure. Now, steroid sparing drugs. What are the steroids? This is the standard question. Discuss the steroid and non-steroid sparing treatments in nephrotic syndrome. Cyclophosphamide, levamisole, mycophenolate mofetil, calcineurin inhibitors, rituximab. 5 drugs are there. I'm going to deal with each one of them very quickly. Primary indication, cyclophosphamide, preferred for FRNS. What is FRNS? Frequently relapsing nephrotic syndrome. Duration, short course with sustained effect. Beware of the gonadal toxicity with cyclophosphamide. Leukopenia can occur. 2 toxicities, gonadal toxicity, leukopenia. So if we are dealing with somebody in before the prepubertal or in the reproductive age, we will not try to give cyclophosphamide. If somebody is past 50, 60 and had nephrotic syndrome secondary, then you are justified in giving cyclophosphamide. Then levamisole, this is also FRNS. Inexpensive, favorable safety profile, long-term use can be considered a good drug, but it is not very effective. Mycophenolate mofetil, MMF. This is steroid-dependent nephrotic syndrome. That means fellow is responding when steroid is there. When you withdraw steroid, is not responding. For such a fellow, the alternative drug will be MMF. Advantage, lacks nephrotoxicity, cosmetic side effects of the calcineurin inhibitor, taper over 3 to 6 months after 12 months of control. We had a boy, we started him on steroid, he showed good response, but within 2 months, he again relapsed. We understood this is going to be the pediatric fellow. We did the genetic testing. Genetic testing showed it is focal glomerular sclerosis, FSGS. We have put him on macrophenate mofetil. Now it is 1 year we have given. Then tapered. Now no more, already 2 years over. No MMF, no. That is how. Calcineurin inhibitor, CNI. SDNS, that is steroid dependent nephrotic syndrome, highly effective, but requires therapeutic drug monitoring, high risk of relapse after discontinuation. Again, the gonadal toxicity problem continues to be here also there. Rituximab in refractory cases, a monoclonal antibody, rituximab you give patients not controlled on at least one other agent, or in case of severe non-adherence to the above drugs, you have to try rituximab. Now let us see each one of them. Steroid sparing matrix, alkylating agents. They come under the cyclophosphamide, comes under the alkylating agent. How much I give? 2 to 2.5 milligrams per kilogram for 8 to 12 weeks. Highly effective for achieving sustained definitive remission in frequently relapsing nephrotic syndrome. Key toxicity, cumulative dose limit, include gonadal toxicity, alopecia, hyperpigmented nails, long-term malignancy risk, and leukopenia. Monitoring requires checking total and differential leukocyte count every 2 weeks for monitoring the leukopenia. Cyclophosphamide offers the best chance for cure in FRNS, but carries the highest reversible toxicity profile. It gives the best chance for cure, but the highest toxicity profile among all the drugs. Now, steroid sparing matrix, anti-metabolites. What are they? Mycophenolate, mofetil, levamisole. How much I give? 300 to 12, 900 to 1200 in an adult per meter square for 2 to 3, 900 1200 milligrams per meter square, adult or child. 2 to 3 years you have to give. Profile, excellent safety profile, avoids nephrotoxicity, highly favored for long-term maintenance. Few GI side effects may be there. What do I monitor? Look at leukopenia and your proteinuria, and also hepatic transaminases you have to monitor, because mild elevation can occur. Levamisole, 2 to 2.5 milligrams per kilogram on alternate days for 1 to 3 years. Levamisole is an anti-parasitic drug, as you might be knowing. Levamisole is a mild agent, but neutropenia and ANCA vascular rash may be occurring. MMF is highly effective, but efficacy drops rapidly upon cessation. Patients be prepared for a 2 to 3 year treatment commitment for mycophenolate mofetil. Steroid sparing matrix. The next one is calcineurin inhibitors. What did we discuss till now? Cyclophosphamide, MMF, levamisole. The fourth one is CNIs, that is calcineurin inhibitor. Cyclosporine or tacrolimus. Doses are given there. Dual action, profound T cell suppression plus direct stabilization of the podocyte actin cytoskeleton. This is a direct benefit on the podocyte, and also it attacks the immunological problem also. CNI paradox, they cause afferent arterial vasoconstriction leading to chronic glomerular toxicity, nephrotoxicity, hyperkalemia, hypertension, gum hyperplasia, hirsutism, tremors, diabetes can occur. Strict target through levels required, and then monitor renal function, electrolytes, uric acid, magnesium. What is the clinical pearl? Tacrolimus is increasingly preferred over cyclosporine due to more favorable cosmetic effect profile, like no hirsutism, no gum hypertrophy. So better you prefer tacrolimus than cyclosporine. Now, steroid sparing matrix. Last one, the B cell depletion, rituximab. Remember what are the steroid sparing drugs? So I have told you how to give the steroid and taper. I am now giving the first one is the cyclophosphamide, second one is mycophenolate mofetil, third one is the levamisole, fourth one is the calcineurin inhibitors, and after that calcineurin inhibitor 2 types, cyclosporine and tacrolimus. Now we have got rituximab. How much? 375 milligrams per meter square. IV infusion, 2 doses, 1 week apart. The dose is 2 doses of rituximab, monoclonal antibody, 1 week apart you have to give. Mechanism, target deep B cell depletion and increasingly utilized by highly complex, steroid dependent and frequently relapsing or CNI dependent cases. Toxicity, infusion reactions, severe infections can occur because it's a B cell suppression, late onset of hypogammaglobulinemia, monitoring, mandatory screening for hepatitis B and hepatitis C prior to use of this drug, because it can active fatal reactivation can occur, hepatitis B and C. Monitor the immunoglobulin level. What does it do? Rituximab targets the CD19 and CD20 lymphocytes with the B antibody there. Ensure complete remission is achieved with steroids, CNIs before administering rituximab. So what you do? First get the obtain remission with steroid or CNI, and to prevent relapse, you give the rituximab to prevent urinary loss of monoclonal antibody. Otherwise, what will happen? When the disease is very severe, when the heavy proteinuria, you are not controlled, give rituximab, this also goes in the urine and wasted. Very costly drug, you are wasting in the urine. So, you control the proteinuria first and then give the monoclonal antibody. So now, the KDIOG selection algorithm now need long-term safety and toxicity. That if that is a concern, choice is MMF or levodopa. Need definitive short course intervention, will be able to accept the risk, cyclophosphamide. Severe SDNS needs podocyte stabilization, tacrolimus CNS inhibitor. Between the two, cyclosporine and tacrolimus is better. Refractory SDNS, CNA toxicity, or patient is not adhering to treatment, give 1 week apart 2 doses of rituximab and be done with it. Because there is no sticking to the treatment here. There is no single best second line agent. What is the first best line agent? Steroid. There is no single best second line agent. Selection is highly individualized based on balancing the patient's specific toxicity thresholds against the severity of the response. Use this table. Now, the prognosis. What will happen? Phase 1, 4 to 8 weeks, I have given oral prednisolone, I have tried steroid, green one, steroid sensitive, complete remission. This side, red side, steroid resistant, no remission. Then come to 6 months time, 0 to 6 months. 6 months, that is phase 2. Patient has come up to 6 months, steroid resistant nephrotic syndrome. Then non-genetic SRNA, patients transition to calcineurin inhibitors plus ACBL. Then 3 to 12 months next. Evaluate CNI response, complete remission, minimize CNI, particularly tacrolimus. Suppose CNI is not responded, classify CNI resistant SRNAs, steroid resistant and CNI resistant, double resistant, prompt clinical trials or multi-drug resistant pathways, rituximab, ofatumumab are the drugs of choice. Now, target proteinuria should be less than 1 gram per day. Multiple observational registries and RCTs have put this level. Clinical trials established this reduction as a valid surrogate marker for improved kidney survival and delayed progression. Is the proteinuria less than 1 gram per day? That means you are on the right track. Regardless of the intervention, lowering the leak preserves the filter. Lowering the leak preserves the filter. Phase 4, steroid-resistant nephrotic syndrome. Lack of complete remission after 4 weeks, SRNS accounts for 15% of idiopathic nephrotic cases, and then precision medical pivot. Genetic testing is now paramount because he has not responded to the steroids. He showed no response. Identifies monogenic forms, structural podocyte mutations, NPH S1, S2 mutations. Patients with monogenic SRNS typically do not respond to immunosuppression. That means if the patient is a genetic condition like NPH S1 or S2, he will not respond to your steroid. He becomes steroid resistant nephrotic syndrome. How do I go? Identifying a genetic cause spares the patient from months of futile, high toxicity immunosuppression and immediately shifts the clinical focus to conservative management. What is the advantage of doing the genetic test when if I do the genetic, I know it does not steroid. I don't have to wait for 6 months, 8 months, all these drugs and waste my time. Okay, that is, then you can go for conservative management or transplant preparation. So this is what you have to understand. Don't go on giving the drug without doing the genetic step. Some stage you have to do that. Now, SRNS, steroid resistant nephrotic syndrome, aggressive treatment protocols. The backbone, initial CNI, tacrolimus or cyclosporin as the primary induction agent. Why? There is already steroid is tried and there is no response. You have to give SCNI inhibitors like tacrolimus or cyclosporin. Then hemodynamic synergy, ACE inhibitor, ARA for maximal antiproteinuritic effect along with the CNI treatment, steroid withdrawal, rapidly taper, discontinue prednisolone, limit toxicity. Refractory state, no response to CMI within 6 months, is double resistant to both steroid as well as CNI. Then what do I have? I still have MMF and or I can enroll him in the rituximab and other trials. In SRNS, that is steroid resistant nephrotic syndrome, CNS are the undisputed heavyweight treatments. The moment patient is not responsive to the steroid sparing drugs and is not responding to steroid, SRNS, that means it is SRNS, CNS are the major stay of treatment. Now, pediatric profile, adult profile. Let's look at the adult profile. High rates of focal segmental glomerular sclerosis and membranous nephropathy, less of minimal change disease. Routine kidney biopsy standard prior to initiating treatment to guide precise therapy. Adult MCD may require much longer initial course of steroid up to 16 weeks to achieve remission. Compare it to prominently mild minimal change disease, very much heavy. You don't require to do any testing. Empirically start on the steroid, biopsy you can wait. If an adult presents, particularly with FSGS or with membranous glomerulonephropathy, you have to identify and do the genetic testing also. Never assume a new adult onset NS to be MCD. Don't assume this is adult, he will be minimal change, I will not do any biopsy, I will just give the steroid. Don't do that. Always do a biopsy to rule out FSGS, membranous nephropathy, or secondary causes like diabetes or amyloidosis in adult. That means what? Slowly, we have to understand that, doing the biopsy is a must for almost all adults. Phase 5, future pipeline and precision therapies. Non-immunosuppressive pathways. Sparsentan. This sparsentan is, I told you, dual DEARA, dual endothelin ACE-ARB receptor antagonist. Sparsentan is the new drug which has got a dual mode of action. Okay, anti-nephrin antibodies. They have got anti-nephrin antibodies, means nephrin is damaged by anti-nephrin. You give auto-antibodies to anti-nephrin. Or next generation biologicals, obinutuzumab. This is also tried. These are the 3 newer drugs. What are the newer drugs? Sparsentan, a dual endothelin angiotensin receptor antagonist DERA. The second one is anti-nephrin antibodies, emerging as the highly specific biomarker for non-invasive monitoring of disease activity in MCD. What do? Measure the anti-nephrin antibodies. That tells you how much is the immunological damage. And next generation biologicals, obinutuzumab is the next type of this. Future NS management relies on shifting from blanket immunosuppression to targeted molecular therapies and non-invasive antibody testing. Ultimate goal, achieving remission, even partial, single most greatest predictor of long-term survival. Keep the proteinuria less than 1 gram. Number 2, supportive dominance. Here, aggressively manage the silent killers, refractory edema, thrombotic risk, hypoalbuminemia. Steroid stewardship, minimize steroid toxicity early using structured, individualized steroid spacing protocols, sparing protocols like mycophenolate mofetil, CNI inhibitors, or rituximab. Precision medicine, screen for genetic mutations early and to spare patients from futile toxic immunosuppression. Core philosophy, treat the patient and not proteinuria. Success requires balancing immunological suppression with severe hemodynamic and metabolic realities of nephrotic syndrome. Now, finally, the concluding remarks are key takeaway nephrotic syndrome management has evolved from purely morphological classification to molecular and clinical response based stratification. Now, to key takeaway two, goal is no longer delaying the progression with the surge of mechanistically unique therapies like SGLT2 inhibitors, endothelin receptor antagonists, DERAs. The 2025 paradigm aims to use synergistic combinations to return the lifetime trajectory of kidney function to a physiological state. You don't have to be afraid of nephrotic syndrome today. You have enough wherewithal and arsenal. You can give them normal life trajectory. Preserve the filter, protect the lifetime trajectory. This is the watchword. Preserve the filter. How do I do that? By active immunosuppression, steroid sparing drugs, and calcineurin inhibitors, mycophenolate mofetil and others, and rituximab, and finally the DERAs and other drugs.